So I'm appreciative of those of you who have stayed to the bitter end, and are. I think this has been for me, a very rewarding conference to be part of, especially the interactions around the patient exams and the cases. It's very apparent to me that you all are an extremely smart and experienced group of practitioners and have a lot of experience, and so it's a pleasure to be working, teaching in a setting like this. So what I'm going to do is wrap up with talking about some of the treatments on the horizon. Paolo has already set the stage for a number of these, since they're going to be tried in both psoriasis and psoriatic arthritis, and so I'll just try to tease out some of the details in relation to PSA. I've added some disclosures here. I don't think I gave these yesterday, but since we're talking about treatments, this is appropriate for me to show you. So this is a table that was created out of an evidence-based literature review that the GRAPPA group did some years ago, and is now undertaking an update of that as we speak. And what we see from this, when we look at the different compartments of the disease, peripheral arthritis, skin and nail disease, spine disease, dactylitis, and enthesitis, what you can see is that we have evidence for the anti-TNFs for effective treatment in all of these domains. We don't for the oral DMARDs in particular, for axial disease, and we just don't have evidence whether or not oral DMARDs like methotrexate work in dactylitis and enthesitis. And before leaving this slide, although my talk is on future therapies, during one of our sessions just now, someone asked about the issue of what's called the MIPA trial. The MIPA, or methotrexate in psoriatic arthritis, was a trial conducted primarily in the United Kingdom and published in 2012. This was a difficult trial, and it did not show evidence that methotrexate was superior to placebo in key outcome measures such as ACR responses, DAS28 responses, and so on. The only outcomes that were statistically superior with methotrexate treatment were the patient global, physician global, and a measure of skin psoriasis area. So we are faced with a conundrum that in a controlled clinical trial, methotrexate doesn't seem to work adequately. There were many problems with that trial, including the fact that it took 5 years to enroll. And when I talked with some of the investigators involved with the trial, it appeared there was a channeling bias, with channeling the least severe patients from their practices into the trial, reserving the more severe patients for biologic therapy. And about a third of the patients dropped out of the trial in both arms. And so with such a flawed trial, I don't think that we can draw an appropriate conclusion from it. And so, unfortunately, we don't yet have a true answer about the effectiveness of methotrexate in psoriatic arthritis. We may in the future, especially when trials of early psoriatic arthritis with patients virgin to methotrexate are randomized to methotrexate monotherapy, biologic monotherapy, and combination therapy. And I'm aware of at least one such trial that's being planned. We might be seeing another trial. So I took a little longer than I anticipated on that, but I wanted to get that point across. Phil Helliwell has reviewed with you the types of measures that we do in psoriatic arthritis trials. I've listed them here in one slide just so that you know what rheumatologists are looking at when they're looking at data from clinical trials. And as you can see, we measure a number of different domains, not only joints, but also skin, pain, fatigue, enthesitis, dactylitis, and a very important part of our evaluation is imaging, demonstrating that an agent can effectively inhibit the progressive damage that we know occurs in the disease. Here in one table is the data from the anti-TNFs. So this is what we are, our current gold standard, if you will, of treatment for psoriatic arthritis patients. And a general conclusion from this slide is that the anti-TNF therapies are equally effective in treating the joint manifestations of psoriatic arthritis as reflected in the ACR composite measure. And for example, in the ACR 20 responses, or 20% improvement of the ACR system, approaching 60%, high 50% range for most of these treatments. ACR 50 response, which is achieved by approximately 40%, and ACR 70 response by approximately 20%. That's a kind of something that you can hold in your mind. Now, arguably, ACR 20 responses are not what we're seeking. We measure them, but this is not enough of a response for us to be satisfied with. We're really looking at a minimum at an ACR 50 response and preferably an ACR 70 response in our patients. And so it's obvious then that this leaves something to be desired. There are patients that are eventually going to achieve this degree of response, say, is this all there is, or eventually lose a response and need to move on to either a different anti-TNF to try or a new therapy with a different mechanism of action. And so that's what we're addressing with the new therapies that are in clinical trials at the moment. There is a bit of difference between the anti-TNFs in the skin, as you know, and that's reflected in this table as well. Although with double dose etanercept, we can get closer to what we see with the monoclonal antibodies. I should pick out certolizumab here. This agent is not yet in Israel, but will be at some point. It is an intriguing molecule that is a FAB fragment, not the full immunoglobulin moiety, but the FAB fragment attached to polyethylene glycol moieties, which prolong its half-life. And it's given either once every 2 weeks or 2 injections every 4 weeks, and has good responses in the joints and skin as shown here. And one of the notable things about the certolizumab trial was that 1/5 of the patients had previously tried anti-TNF therapy and had a secondary failure, meaning they initially benefited and then lost response. Yet with certolizumab, there was as good an effect in this trial as in patients who had not seen anti-TNFs before. So it looks as though this agent, like others that we've experienced, can work in people that have previously tried other anti-TNFs. And importantly, we have shown in the anti-TNF trials that other domains such as enthesitis, dactylitis, function, quality of life, fatigue, all improve. And I've given you some rough numbers that are similar between the different anti-TNF agents. And importantly, all of them have shown ability to inhibit progressive structural damage. So what else can we look at in the patients that are anti-TNF failures? So I first mentioned 3 drugs that are current RA currently used for rheumatoid arthritis, and I'll make a few comments about these. And then recently we've had ustekinumab join this group, but I'm going to talk about that a little bit later. So first of all, with IL-1 inhibition, there was one very convincing trial done in Dublin that showed no effectiveness of the drug anakinra. This was a trial that included clinical outcomes as well as MRI and even synovial biopsy outcomes, and it could not be demonstrated to be superior to placebo. So that's not a place that we would go. Co-stimulatory blockade is an interesting approach because this focuses on T cell modulation, so you would anticipate it to be effective in psoriatic arthritis because of the amount of T lymphocyte activity in the disease. And we already have seen approvals for Alefacept a number of years ago. It was actually the first biologic to be approved for psoriasis. Abatacept has been approved for the treatment of rheumatoid arthritis and is now in phase 3 trials for treatment of psoriatic arthritis, and I'll show you some data with that agent. B-cell ablators and modulators, ablators such as rituximab, have been tried in case, have been shown to have some modest efficacy in case reports and one open-label trial of 20 patients. But the effect was modest, and there's virtually no effect on the skin. And so it won't be in clinical trials for approval. But for example, if you have a patient who's had psoriatic arthritis and, say, a history of lymphoma, there is at least some open-label data that suggests that it could be effective. Here you can see the concept of co-stimulatory blockade. An antigen-presenting cell presents to a T lymphocyte first through signal number 1, which is the MHC interacting with the T cell receptor. But in order for the T lymphocyte to be activated, there has to be a second signal that occurs as well. The drug Alefacept worked by the interaction of LFA3 and CD2, efalisumab by ICAM1 and LFA1, and then abatacept through the interaction of B7 and CD28. And that drug inserts itself and inhibits the second signaling, thus diminishing T lymphocyte responsiveness. Here is data from a phase 2 study that was conducted and shows, if you focus in on the 10 milligram per kilogram and the kind of yellow gold bars, we can see an ACR20 response that's in the high 40% range, not nearly what we have seen with anti-TNF therapy. If you separate out the patients in this trial who were not on prior anti-TNF therapy, which is the numbers are shown here, you can see that the responses are closer to what we have seen with the anti-TNFs, up in the mid 50% range. So it's based on this finding that has led BMS to proceed into phase 3 with this drug, with the hope that, especially when it's used earlier on in the treatment paradigm, that we can see some good effects with it. One of the reasons why there is some encouragement about using it is that in many ways it's a relatively safe biologic agent. Its rate of serious infection is not quite as high as with the anti-TNFs, and it doesn't have other unusual side effects like the potential for multiple sclerosis or that sort of thing. And so there's some potential advantages to it. However, when you look at its response in the skin, that was not very good. What I have shown here is the PASI 50 response. This isn't even a PASI 75 response, and that's down in the 40% range. So unfortunately, its benefits in the skin were minimal to modest, and so we're going to have to be selective. If we have a patient with moderate to severe psoriasis, this may not be the drug for them to use. Now, in the rest of the talk, I'm going to focus on some agents that Professor Jasandi has already emphasized in psoriasis, and I'll take a look at what we know about their effectiveness in psoriatic arthritis. First, with IL-12/23 inhibition. Let's think about, again, remember the talk from yesterday, and what we're looking at here is, let's see if I can get this I can't seem to get this pointer to work. But down in the lower right-hand corner, you can see that IL-23 is an important cytokine which is important in Th17 cell activation and proliferation, and which then leads to the production of various cytokines like IL-17. So that's where the IL-23 component of ustekinumab would appear to work in the Th17 pathway. IL-12 would appear to work in the Th1 pathway. The way ustekinumab works is by targeting the P40 subunit of both the IL-12 and the IL-23 cytokine moieties, leading to Th1 and Th17 cell down regulation. Here is data from what is known as the Summit-1 trial, in which patients were entered who had not seen anti-TNF therapy before, were all methotrexate inadequate responders. And what is shown is that in the dose of 90 milligrams given every 3 months after an induction dose, that 49.5% of the patients achieved an ACR20 response. With the 45 milligram dose, this was 42%. Again, not quite as robust as what we've seen, obviously, with the anti-TNFs. In the skin, this drug, as we know, works very well, and these are the PASI 75 responses in this psoriatic arthritis trial. There was a second study that was done called Summit-2. By the way, the P is silent in these trial names. And in this trial, roughly 2/3 of the patients had previously seen anti-TNF therapy. And what you can see here is that the effectiveness of the drug in that group of patients. So around 35-37% ACR20 responses, 15 to 16% ACR50 responses, et cetera. So again, since the population we're most wanting to see the drug work in is those patients that have already tried and failed anti-TNF agents, these numbers are less than what we would have ideally hoped for, but still show separation from placebo. And so I think it's still reasonable to try this agent in patients that have failed previous anti-TNF therapies. And in some of the cases, the difficult cases that we were discussing this morning, I think ustekinumab could have definitely been one of the options in patients who had had either adverse effects to or lost effectiveness with the anti-TNFs. And we know that the drug works very well in the skin. At the recent ACR meeting this past fall, we had data presented which showed that the drug could inhibit progressive X-ray damage, and that's an important aspect of being able to demonstrate that with these drugs, and that's what's shown in this particular slide. And then they also presented in the recent ACR meeting 2-year data. Now, you always have to take long-term data with a grain of salt, because people who did not do well with the drug have dropped out along the way, and so we're looking at a completers analysis. But nonetheless, what this shows is that in patients who had benefit from the drug, there is persistent benefit, and actually there might even be some climbing of benefit over that period of time in some of those patients that have responded well. And you can now see ACR20 responses up in the 60% range. Also commented here is that there was improvement in enthesitis and dactylitis scores. All right, now let's turn to the IL-17 inhibitors. And I'm only going to show you data with one agent, but I'm going to make a couple of comments about the other two. So there was a pilot, the data I'm going to show you is with brodalumab, which is, as Professor Jasandi said, an IL-17 receptor inhibitor. So it theoretically inhibits both IL-17A, F, but also there's something called IL-25 that it inhibits, which is why it's being studied in asthma as well. Secukinumab, we have pilot data with that over a 6-week period, which shows some efficacy, and it is now in robust phase 3 trials, but we don't have the data from those yet. Ixekizumab is just beginning its clinical trial program in psoriatic arthritis. I should mention that we have some data in rheumatoid arthritis with all 3 of these agents. The effect of secukinumab and ixekizumab in rheumatoid arthritis is modest. There is some separation from placebo. Interestingly, with brodalumab, a phase 2 trial in our rheumatoid arthritis showed no effectiveness at all. There was no separation from placebo. So that drug is not going forward in rheumatoid arthritis, and it's not clear to me whether there will be any traction with the other agents in rheumatoid arthritis in the long run. Clearly, their benefit is much greater in psoriasis, where, and this is a single slide showing some phase 2 data with these drugs in psoriasis. And as I sometimes comment, you just practically have to breathe the drug and the psoriasis goes away. So that's one of the reasons why it's very difficult to do a true controlled trial, placebo-controlled trial, because once you see after the first injection or two, the patient's psoriasis going away, you can almost tell what they're on. So let's move then to the PSA data. This is with brodalumab. In the phase 2 trial, it was arbitrarily chosen for week 12 to be the primary endpoint. And this is the data at week 12 with an ACR20 response in the 280 milligram dose, 39.3%, 140 milligram dose, 36.8%. So you might look at these numbers and go, gee, this isn't very effective compared to what we know with the anti-TNFs. Then you look at the 24-week data in which the patients were on open label between week 12 and week 24. And what is shown is that there is a consistent improvement. On the left, we see ACR20 responses. On the right, we see ACR50 responses. If you look at ACR70 or DAS28 responses or dactylitis responses or skin responses, all of them tend to increase between week 12 and 24. And so either this is an artifact of the patient knowing now that they're on the drug, or it's a reflection of the fact that the drug takes longer to work in the joints than we would typically expect for a biologic. For example, with the anti-TNFs, you get a lot of the response that you're going to get by week 12. But here it's looking as though there's further improvement. So in the phase 3 program with this drug, the primary endpoint is going to be week 16, and where we see that seems to be a reasonable time frame where we can keep it placebo-controlled. And it will be very interesting to see in a larger, more robust program how this is. The other thing I should mention is that in those patients, let's see if I have that, I don't. So in those patients who were on anti-TNF therapies previously in this trial, their effectiveness was the same whether or not they had been on anti-TNFs previously. So there's some hope and reassurance to take from that we may be able to get some good responses in people that have already been on anti-TNF therapy. So I think we're going to stay tuned and see with this agent, as well as the other 2 IL-17 inhibitors, whether or not it's a phenomenon of just needing to wait a little longer and then achieving responses that are more in the range that we expect from the similar to the anti-TNF therapies. I'm not showing detailed safety data with this agent, but the take-home message is that there were a few serious infections, not many, and the overall safety profile has been very good with the IL-17 inhibitors. This is data showing improvement in dactylitis. In this trial, there was no change in enthesitis. Okay. Now, I want to move on to interleukin-6 and just make a couple of comments. Interleukin-6 is an important central cytokine in inflammation. It's somewhat similar to TNF in that regard. And we have very robust data with one IL-6 receptor inhibitor, tocilizumab, in rheumatoid arthritis that shows that it's very effective there, and it's approved generally globally for treatment of rheumatoid arthritis. We know that IL-6 is richly expressed in the skin and synovial tissue in psoriatic arthritis patients. There have been some case reports with tocilizumab, some showing great effect, some showing absolutely no effect. So it's unclear what a general psoriatic arthritis program will show us, but we are going to see data in the near future with a direct IL-6 inhibitor that is being developed by Bristol Myers, which about its effectiveness or not in psoriatic arthritis. So I do expect some development of IL-6 in this arena. You've already seen this slide. This slide speaks to the intracellular signaling pathways of immune cell activation. And what we're focusing on next is the fact that the JAK inhibitors are being developed in psoriatic arthritis as well as psoriasis, and they're noted on the far right. The first of these, tofacitinib, is now in clinical trials in psoriatic arthritis after having successfully shown benefit in rheumatoid arthritis treatment. The accepted dose in the United States for tofacitinib is 5 milligrams twice a day. The FDA decided not at the moment to allow the 10 milligram twice a day dose being used until more safety data had been accumulated in continued use of the drug. And so the 15 milligram twice a day dose that was that Professor Jasandi showed in the psoriasis trials will not be employed. And so in the phase 3 program, they're using 5 and 10 milligrams twice a day with the hopes ultimately that we will have access to both of those doses of the drug. So stay tuned for the effectiveness in psoriatic arthritis. Lastly, I would like to talk about apremilast. This is an intriguing drug. It's oral. It's a phosphodiesterase 4 inhibitor. And this is a slide which kind of highlights the mechanism of action. So cyclic AMP is converted to AMP through the action of this enzyme phosphodiesterase 4. Apremilast comes along and inhibits this enzyme, which then leads to a cascade of effects in the cell and leads to a decrease in several pro-inflammatory mediators that are listed here and an increase in several anti-inflammatory mediators. So this drug has had some data in psoriasis, and I'll make some comments about that in a moment. But the main focus for its development has been in psoriatic arthritis. There's been some fledgling data in rheumatoid arthritis and ankylosing spondylitis, but their first indication is PsA, and there will be a decision in March of this year about its potential approval in the United States, and we are expecting that it's likely to be approved. So here we have data from the first phase 3 trial with this agent, and we're looking at ACR20 numbers that are in the 40% range with the 30 milligram twice a day dose, and then correspondingly lower ACR50 and 70 results. And in a moment, I'm going to tease out some of the subsets of the patient in this trial with some more data. But before doing so, I want to make the comment that one of the even though this drug may be modest in its effect, its safety profile is remarkably good. It's got some tolerability issues in that early on in its use, a number of patients will have nausea or diarrhea. But most of that tends to resolve if the patient keeps using the drug over the course of a month or so, and then those side effects tend to diminish and go away. And in terms of serious infections, neoplasm, et cetera, again, the safety profile was just fantastic. So what we're anticipating, and if you look at in the right-hand side of this slide, a Primulast monotherapy biologic naive. This is the population that we're expecting this drug to be used. Maybe after methotrexate, the patient's a little nervous about going on to a parenteral anti-TNF agent. This may be a drug that would be employed in such a patient at that juncture, especially if they're very safety conscious. Here is data that was presented at the ACR meeting and in this past fall with the 4th phase 3 trial with this drug in patients who had not seen methotrexate previously. And these are the data at week 16, modest to say effects. But again, in this trial, as you track patients along longer, there was some increasing benefit in those that had some response. So again, I think there is going to be a real place in this, especially because of its beneficial safety profile. And here is data that Daphna presented at the ACR meeting showing effectiveness in enthesitis and dactylitis. This is data in the skin lesions in the psoriatic arthritis trials. This is PASI 75 response. So this is my last slide, and I just want to end with a number of questions, and that is, as we look at the data with these new drugs, we always want to be asking beyond the joints and the skin, what is the effectiveness in other clinical domains, such as enthesitis, dactylitis, nails, and spine, because of the, as we've learned over these 2 days, the very heterogeneous nature of psoriatic arthritis. We're going to be increasingly interested in looking at the percentages of the patients that can achieve remission or minimal disease activity now that we know that we've got a target of trying to achieve those goals in psoriatic arthritis treatment. And because we have learned that the special pathophysiology of psoriatic arthritis leads to both erosive disease as well as osteoproliferative disease, we're going to be interested in seeing if any of these new drugs are able to switch hit between prevention of erosions and prevention of osteoproliferation. With a couple of these, including tofacitinib and the IL-6 inhibitor, we're also going to be especially focused on some safety issues, including the potential for LFT abnormalities and the potential for increasing lipid levels because of the unique issue of psoriasis and psoriatic arthritis patients in terms of their proclivity to having metabolic syndrome. So these are the kinds of things that we'll be looking for in the future as we look to what is there beyond the anti-TNFs for our patients that are failing these. So thanks very much for your patience.